So hello guys, so in this video we are going to learn about inflammatory diseases of eyelid. Okay, so first of all we are covering inflammatory diseases of lid margin. This video is of lid margin. Okay, so first of all I would like you to know lid margin. It is divided into two parts, that is anterior lid margin and posterior lid margin. Okay, anterior and posterior. So focus on the labelings here. See, in anterior we have Zeiss gland. Okay, Zeiss glands are nothing but modified sebaceous gland, and in posterior you can see this thing. This is meibomian gland. Okay, meibomian glands are arranged vertically. Okay, 20 to 40 in the upper eyelid and some 20 around in the lower eyelid. Okay, meibomian gland which secretes lipid material. Okay, which forms the oily layer of the tear film. Lid margin is divided into two parts, that is anterior lid margin and posterior lid margin. So inflammations of lid margin. One is blepharitis, okay, which is a 5 marks question. The blepharitis is a subacute or clonic inflammation of the lid margin. Okay, it is a subacute or clonic inflammation of the lid margin. See the classification. Classification divided into anterior blepharitis and posterior blepharitis. Anterior blepharitis means anterior part of the lid margin. Okay, it is divided into three parts: bacterial ulcerative blepharitis, seborrheic or squamous blepharitis. Another one is mixed. Mixed is, that is by staphylococcus and seborrheic blepharitis. Okay, mixed of both two. Next is posterior blepharitis or meibomianitis, and other one is parasitic blepharitis. So we are going to cover all this. First, coming to the anterior blepharitis, in that we have bacterial ulcerative blepharitis, chronic anterior. Okay, anterior lid margin is now, that's why. Next is staphylococcus blepharitis or ulcerative blepharitis. All these are same only. Okay, these are the chronic inflammation of the anterior part of the lid margin. Okay, chronic infection and inflammation. Most common cause is ocular discomfort and irritation. Starts in the childhood and present throughout and continued throughout life. Okay, etiology. Causative organism is Staphylococci, Streptococci, Propionibacterium acnes, and Moraxella. Okay. Predisposing factors are chronic conjunctivitis and dacryocystitis. Now coming to the clinical features. Okay. Clinical features, symptoms are chronic irritation, itching, gluing of the eye, mild lacrimation, mild photophobia. Okay. In majority of the lid margin inflammations, all the symptoms are same only. Then the worsening is seen in the morning time and remission and exacerbation may occur. Now coming to the, what are the signs of a bacterial blepharitis, okay, or anterior blepharitis. There is formation of yellow crust, okay, and there is gluing of the cilia together and by forming the yellow crust. Next is small ulcers that bleed on removal of the crust. Okay, when you remove that yellow crust, there will be bleeding. Okay, red and thickened lid margin with dilated blood vessels which appear as rosettes, mild papillary conjunctivitis and conjunctival hyperemia. Hyperemia means reddening. What are the complications? Okay, complications are understood by this simple diagram only. Now coming to the complications. Okay, complications is, go with order. Okay, first coming to lid lashes. Lid lashes is madarosis. Madarosis means absence of eyelashes. Trichiasis means misdirected eyelashes. Next is pileosis means graying of the eyelashes. Next is lid margin. For lid margin, there is stylosis. Stylosis means thickening and inflammation of the lid margin, and ectropion. Ectro means aversion of the eyelid. Next is you can see 4, that is recurrent striae or external hordeolum. 5, you can see eczema of the skin due to prolonged watering. Okay. 7 is marginal keratitis, that is a phyllectonulosis. There is a secondary inflammation and mechanical changes occurring in a cornea and conjunctiva. Next, there is tear film instability which causes dry eye disease, and there is punctum which get everted and causes epiphora. Okay, the same thing is written here. I want you to read by yourself. Okay, go through it, pause the video and read it. Okay, now coming to the investigation. Investigation is by history and clinical examination. Now coming to treatment. Treatment of anterior blepharitis or bacterial blepharitis. Okay, it is by maintain the lid hygiene, that is by twice a day, by warm compression by 5 to 10 minutes or soft crust. Next, by cold crust removal by cleaning of the lid margin. Cotton bud dipped in 1.4 diluted baby shampoo or 3% sodium bicarbonate solution. Avoid rubbing of the eye with fingering or lids. Means there is formation of crust. Okay, if you rub, there will be damage to your eye only. Next, use antibiotics. Eye ointment applied as soon as possible after crust removal. Eye drops 3 to 4 times a day. Oral erythromycin or doxycycline is used if unresponsive patient in complicated by the external hordeolum or abscess of the lash follicle. Topical steroids are used, that is a low potency topical steroid, that is fluoromethalone, in patients with marginal keratitis and papillary conjunctivitis. Next is ocular lubricants, that is carboxyl methyl cellulose, to prevent dry eye disease. Okay, what you will use? First, there is you will maintain hygiene, that is by 3% sodium bicarbonate or baby shampoo. Next is antibiotics, that is doxycycline or erythromycin. Next is topical steroid, that is low potency one, that is fluoromethalone. Next is ocular lubricants, that is artificial tear drops, carboxyl methyl cellulose. After bacterial ulcerative blepharitis, now coming to seborrheic or squamous blepharitis. Okay, it is a primary anterior blepharitis with some spill over the posterior margin. Okay, posterior lid margin. Etiology is causative organism, that is Corynebacterium acne, associated with seborrhea of the scalp. Okay, there is dandruff in the person. Okay, pathogenesis is a gland of Zeiss. You already show anterior lid margin has some glands. Okay, those glands of Zeiss, that they are nothing but sebaceous gland, modified sebaceous gland. Okay, abnormal excessive, they produce abnormal excessive neutral lipids, and these neutral lipids are split up by the Corynebacterium acne and causes irritating free fatty acids. Okay, gland of Zeiss produces sebaceous secretions that will be broken up by the Corynebacterium acne, which causes irritating solution. Next, what are the clinical features? Because of that irritating free fatty acids, there is a symptoms occur. Deposition of whitish material, that is soft scales at the lid margin, mild discomfort, irritation, watering, and history of fall of eyelashes. Okay, signs are important. Accumulation of white dandruff like scales on the lid margin. On removal of the scales, hyperemia and greasy under surface, there is no ulceration. Fall of eyelashes and they are replaced quickly. Next is lid margin get thickened and sharp posterior margin rounded along with epiphora. Okay. Now complications are same as that of bacterial ulcerative blepharitis. Management. Next is treatment. General measures: improve the health and balanced diet associated with dandruff, if dandruff should be treated. Okay. Next, local measures should be taken. Removal of the scales with a lukewarm 3% sodium bicarbonate solution, baby shampoo. Another one is antibiotics and a steroid eye ointment. Same only. Okay. Now coming to the posterior blepharitis. Just now finished the anterior blepharitis. Now coming to the posterior blepharitis, is also known as mebominitis. Okay, mebominitis is nothing but inflammation of the meibomian glands occurring in acute and chronic. Okay, meibomian glands are arranged vertically in the eyelids. Okay, it is of two types: chronic meibomianitis, that is meibomian gland dysfunction. Another one is acute meibomianitis. First, we will finish chronic meibomianitis, or it is caused mainly because of meibomian gland dysfunction. Most common occurs in middle-aged person or in those with acne rosacea or seborrheic dermatitis. Main pathogenesis is by bacterial lipase. Okay. Clinical features: there is burning, itching, chronic irritation, grittiness, mild lacrimation with remission and exacerbation intermittently. Signs: white frothy foam like secretions along the eyelid margin and canthi. Okay, you can see white foamy like secretions on the eyelid margin and canthi. Opening of the meibomian gland, there is a prominent with thick secretions expressed out by pressure, by putting pressure on the lid. Okay, there is toothpaste appearance of that secretion. Meibomian gland orifices, they can be there will be capping of the opening. Okay, that is by oil globules or pouting or recession or plunging. Okay. On eversion of the lids, means when you avert the lid, you can see vertical yellowish streaks shining through the conjunctiva. Next is hyperemia and telangiectasia of the posterior lid margin associated with meibomian gland orifice. Oily and foamy tear film with the accumulation of froth on the lid margin and inner canthus. Secondary changes in the papillary conjunctivitis, that is infection of the corneal punctate epithelial erosions. Okay, complication is by chalazion. Infection of the cornea, there will be corneal erosion, papillary conjunctivitis, tear film instability. Acute meibomianitis, that is due to staphylococcal infection. Now, just now finished chronic. Next is acute one. Acute is by staphylococcal infection, but this will be painful swelling around the involved gland. Okay, when you put pressure on that, there will be first pus bead, then followed by serosanguinous discharge. Treatment of both meibomianitis is by maintain the lid hygiene. Once in a day at least, warm compress should be given several minutes. Then milking is nothing but you will do vertical massage of the lids. Okay, there will be expression of the accumulated secretion. Topical antibiotics, that is eye ointment, rubbed after just applied as soon as possible after rubbing of the lid margins. Next is eye drops 3 to 4 times a day. Systemic tetracycline, that is doxycycline, will give 100 mg 2 times a day for 1 week. and then once in a day for 6 to 12 weeks. Doxycycline is a treatment of choice, okay, because it blocks the staphylococcus staph lipase production. Next, if the tetracycline are contraindicated, then erythromycin is used. Erythromycin is a macrolide. Next is orbital lubricants, that is artificial teardrops. Carboxymethyl cellulose is used to prevent dry eye disease. Topical steroid is used for that is a low potency fluorometholone in patients with papillary conjunctivitis. Now coming to the last thing, that is nothing but parasitic blepharitis or lash infection. Lash means that is eyelash infection by lice. Okay, lice is nothing but no head lice. Lice infestation by the lashes in a person living with a poor hygiene. That is of three. That is Fistariasis palpebrum. That is infestation by Thysis pubis, that is crab louse, most commonly seen in adult as sexually transmitted infection. Pediculosis, infestation by Pediculosis humanis or corporis or capitis. Capitis is by head loss. Involve lash if heavily infestation. Next is Demodex blepharitis. If Demodex folliculorum is there, that is will be anterior blepharitis. If Demodex brevis is there, then it will be posterior blepharitis. Clinical features of this parasitic are infestation of lash with lice that causes chronic blepharitis or chronic follicular conjunctivitis. Symptoms are same: chronic irritation, itching, burning and mild lacrimation. Signs are lid margin are red and inflamed, and when on slit lamp examination you can see lice anchoring to the lashes with claws. Okay, nits are nothing but the eggs of the lice seen as opalescent pearls adherent to the base of the cilia. On long-standing cases, conjunctival congestion and follicles are seen. Treatment is by mechanical removal of the lice and nits with the use of forceps. Okay, you should take forceps and remove all the lice and nits. Applying antibiotic ointment and yellow mercuric oxide 1% is applied to the lid margin and lashes. Okay, delousing of the patient, family members, clothing, bedding, and preventative measures should be taken. Just have a look at the pictures of the bacterial blepharitis. Bacterial blepharitis, you can see the yellowish crust in the upper eyelid. Okay, and there will be medarosis. There is some missing of the eyelids, and there piling of the eyelids also. Then eyelids form cluster. This is bacterial blepharitis. Next, coming to the seborrheic blepharitis. Seborrheic blepharitis, you can see there is in anterior lid margin, the gland of Zeiss form the whitish foamy things on the base of the hair follicles. Okay, this is by seborrheic blepharitis. Next is chronic mebomonitis. It is of the posterior lid margin. Okay, this is the anterior lid margin. This is the posterior lid margin. You can see whitish foamy things at the base of the meibomian gland. This is the plunging or there will be oily deposits at the base of the meibomian gland. Okay, meibomian glands are arranged vertically like this thing. Okay. Next, you can see Pityriasis palpebrum. Okay, on slit lamp you can see the lices or lows are attached to the hair follicles with the help of their claws. Okay, both nits and nits are eggs of the lice. Lice and nits are removed with the help of a forceps, and palliative treatment is given. Once again, blepharitis is the inflammation of lid margin. It classified into anterior and posterior. In anterior blepharitis, bacterial ulcerative blepharitis, seborrheic or squamous blepharitis, and another one is mixed. Next is posterior blepharitis, that is mebobenitis, and is parasitic blepharitis by lice. Okay.